Good morning, everyone. Today, Dr. Prarthana Govil, Senior Lecturer, Bhavanasidhas Dental College, I will be taking a small discussion about clinical examination. Talking about a case history is defined as a planned professional conversation that enables the patient to communicate his or her symptoms, feelings, and fears to the clinician so as to obtain an insight into the nature of patient's illness and his or her attitude towards them. Now, starting a case history, you have simple steps to follow. First of all, you need to assemble all the available facts gathered from the statistics like chief complaint, medical history. Then you have analyzed and interpretation of all the assembled data. Then taking out of a provisional diagnosis, helping you to make a differential diagnosis, select the closest possible choice that is final diagnosis, and then you need to plan an effective treatment accordingly. So the components of case history are statistics, chief complaint, history of present illness, medical history, past dental history, personal history, general examination, extraoral examination, intraoral examination, provisional diagnosis, investigations, final diagnosis, treatment plan. Now, cranial nerve examination. Cranial nerve examination includes the cranial nerve 1, that is olfactory nerve. The function can be tested by asking the patient to identify familiar odors such as coffee, tobacco, and mint, but not ammonia and acetic acid, which stimulate the fifth cranial nerve. Each nostril is tested with the eyes closed. Talking about cranial number 2, that is optic nerve, we have two things to be tested that are visual acuity and visual field. Visual acuity is tested with an eye chart placed 20 feet away from one eye at a time that the other eye having covered, and visual field is tested done by confrontation by wiggling fingers 1 foot from patient ears, asking which they see move. Cranial number 3, that is oculomotor nerve, it supplies all orbital muscles except the superior oblique and lateral rectus. It controls all muscles of accommodation. Oculomotor nerve controls most of the eye movement and upper lid movement. It can be tested by asking the patient to follow the examiner's finger 20 inches away towards right, left, upward, and downward direction. Cranial number 4, that is trochlear nerve, it innervates the superior oculi oblique muscle. To check the function, the patient is asked to roll the eyeball upwards and laterally. Cranial number 5, that is trigeminal nerve, important in the case of a dental patient, you need to know how to test the trigeminal nerve. It has sensory and motor divisions. It supplies the sensation to the subclavian and deep structures of the head and face, and motor functions to the muscles of mastication. Testing of the sensory division is done by pinprick and light touch of a cotton tape applicator to determine diminished or no sensation compared with the contralateral side or other division. Cranial number 6, that is abducens nerve, it innervates lateral rectus muscle. It can be tested by asking the patient to rotate the eye laterally and in a downward direction, and if dysfunction is present, it causes double vision. Facial nerve, another most important nerve in a dentistry. We need to know, all the students should know how to test facial nerve because maximum patients have dysfunction in the facial nerve when they visit our clinic. So first look at the patient's face. It should appear symmetric. That is, there should be the same amount of wrinkles apparent on either side of the forehead. The nasolabial fold, lines coming down from either side of the nose towards the corner of the mouth should be equal. The corners of the mouth should be at the same height. Ask the patient to smile. The corners of the mouth should rise the same height and equal amount of teeth should be visible on either side. Ask the patient to puff out their cheeks. Both sides should puff equally and air should not leak from the mouth. Cranial number 8, that is auditory nerve, supplies neural function for hearing and balance hearing. It can be tested by using Weber test or Rain test with a tuning fork. Balance can be tested by asking the patient to close the eyes and move. Now, if the semicondylar canals are normal, no difficulties detected in the movements. Cranial number 9 is a glossopharyngeal nerve. Now, examine the pares of the uvular displacement. Check for gag reflex. Cranial number 10, vagus nerve. Check for gag reflex. Check for taste sensation, the posterior part of the tongue. Ask the patient to open their mouth and say, ah. causing the soft palate to rise upward. Case number 11 is check for shrugging of shoulders. You need to shrug the shoulders of the patient and see whether they are shrugging properly. Place your hand on the top of the either shoulder and ask the patient to shrug while you provide resistance. This function will cause weakness, absence of movement of the affected side. Case number 12 includes the hypoglossal nerve. Now, for this, you need to inspect the tongue for the deviations. That is, you tell the patient to protrude out his tongue and deviate to the left and the right side. Now, once the general examination is finished, you need to do the extraoral examination in the patient. Now, first of all, their skin is look for appearance of any rashes, sores, or itching. Any color changes in anemic patients have pale skin color, yellow tint in jaundice patient, pigmentation, edema, temperature of the skin. Temperature is right now very important in COVID times, wherein to take the history of the or to detect the COVID, one of the symptoms is severe high temperature of the patient. Facial symmetry, bilateral, symmetrical or asymmetrical. Lip consistency, lip should be confident or incompetent. You need to check that. Eyes, inspect external eye structure for position and alignment. Position and alignment and exophthalmosis, strabismus, and indicator of anemia and jaundice is the eye. Now, infection of maxillary teeth may extend to a vital region, causing swelling of eyelid and conjunctivitis. Now, check the nose. Nose size should be 1/3 of the total facial height. Deviated nasal septum involve mouth radius and saddle nose in congenital stiffness. Now, check for jaws. Any deviation in path of closure and opening, lateral movements of mandible, tenderness over the joint and muscles of mastication. Any injuries, trauma to the facial bones and jaws should be examined. Now, talking about temporomandibular joint, you need to check about the clicking or cropping sound. You need to check about the deviation and reflection while opening of the mouth. Check the pain and tenderness of the joint or masticatory muscles. The maximum intestinal opening is about 35 to 50 mm. Anything less than that and more than that is normal. And range of vertical and lateral movements have to be checked in each and every patient to judge a problem in temporomandibular joint. Now, palpation of pretragus area, the examiners can be positioned either in front or behind the patient. Patient is asked to slowly open and close the mouth, palpating the index finger placed in the pretragus depression. Here you need to put and palpate in the pretragus area for the opening of the and closing of the joint. Intra-auricular palpation performed by inserting small finger into the ear canal and pressing anteriorly. While palpating with this method, check whether condyle moves symmetrically while the rotation and the translation phase. Now, talking about the muscles of mastication, the palpation of muscles of mastication can be helpful in the determination of temporomandibular joint dysfunction in the discovery of other abnormalities. There are 4 muscles: temporalis, masseter, internal pterygoid, and external pterygoid. Temporalis muscles origin in the fossa of the temporal bone and insert on the conite process. The muscle can be seen and readily palpated throughout its entire length, breadth when the patient's teeth are firmly clenched. The masseter muscle originates from the lower portion of the zygomatic arch. It inserts on the lateral surface of the angle and conite process of the mandible. Now, palpation of the muscle in the body of the muscle can be palpated with thumb and the index finger, as you can see in the figure. Internal pterygoid muscle, it originates from the medial side of the lateral pterygoid plate and the tuberosity of the maxilla, and they cannot be palpated. Now, it can be insertion is there on the lower medial surface of the amas of the mandible. Now, the interior part of the insertion can be palpated by placing the index finger at a 45-degree angle, as you can see in the figure, in the base of the relaxed tongue. The opposite hand can be used extraorally to palpate the posterior and inferior portions of the insertion. The body of the muscle can be palpated by rotating the index finger upward against the muscle to near its origin on the tuberosity. Talking about the external pterygoid muscle, in 2 parts, one begins on the greater wing of the sphenoid bone and the other issues from the lateral surface of the pterygoid plates. Now, insert on the neck of the condyle and the articular disc of the AMJ. The muscle is palpated by using the index or the little finger and placing it lateral to the maxillary tuberosity and medial to the coronoid process. The finger presses upward and inward and the painful response can be determined. Now, there's a lymph nodes being present in the head and neck region. You need to check when the patient arrives in your clinic. Now, lymph nodes are oval and bean-shaped structures found along the lymphatic vessels that drain body parts. Normally, they are non-tender, soft, and cannot felt even though they are present. Tender on palpation, mobility should be noted. Now, there are preauricular lymph nodes in front of the ears, lymphatic drainage of eyelids and conjunctiva, temporal region, and pinna. Now, for palpation of preauricular lymph nodes, roll your finger in front of the ear against the maxilla. Enlarged external auditory canal infection can be present. A postauricular lymph nodes, the location is behind the ear, near insertion of sternomastoid muscle, lymphatic drainage of external auditory meters, pinna, scalp. If it is enlarged, then it could be due to infection of the scalp, temporal, and frontal areas. Occipital lymph nodes, location located at the junction between the back and the head of the neck. Scalp and head is the lymphatic drainage area. And if it is enlarged, you can look for the infection of scalp and also syphilis. Submental lymph nodes, location below the chin. Now, lymphatic drainage of lower lip, floor of mouth, teeth, submental salivary gland, tip of the tongue, skin, and cheek. Roll the fingers below and lingual of the chin against the mylohyoid muscle. Enlarge disorders in the anterior portion of the mouth and the lower lip. Submandibular lymph node located medial to the inferior border of the mandible. Lymphatic drainage area of tongue, submaxillary gland, lips, and mouth. Roll your fingers against inner surface of the mandible. Patient's head gently tilted towards one side. Enlarged infections of head, neck, sinuses, ears, eyes, scalp, and pharynx. Cervical lymph node, two chains of cervical lymph nodes present on either side of sternomastoid muscle. Locations anterior cervical located anterior to the muscle and post cervical located posteriorly. Palpation of anterior chain, patient's head is tipped slowly forward in area medial to sternomastoid muscles pressed with examiner's finger. For post chain, fingers are kept behind the muscle. Palpation starts from trapezius muscle and move to the sternomastoid muscle. Now, once the lymph node examination is over, you need to check for the intraoral examination, which consists of soft tissue and the hard tissue. Soft tissue is the labial and buccal mucosa, lip, floor of the mouth, tongue, salivary, and gingiva. Hard tissue consists of teeth present, teeth missing, carious teeth, wasting disease, mobility, and occlusion. Soft tissue, you check about the labial and buccal mucosa, you check about the ulcer, white patch, or neoplasia, and pigmentation. Lip, check the color, texture, palpate upper lip and lower lip for any thickening or swelling. Check about the cleft lip, lip pits, ulcer, nodules, carotid flap, and scars. In the floor of the mouth, check for any swelling. If there is a granular, appears as an anterior unilateral bluish translucent cyst over Wharton's stuff. Ankyloglossia will occur. You will see it as a fusion between tongue and the floor of the mouth. Carcinomas are common in the floor of the mouth. Ulcers are red and white patches. Now, tongue, you should examine the volume of the tongue, integrity of the papilla, check for any crack or fissures, check the swellings or ulcers present on the tongue, and presence of tongue tie. Now, how do you check the tongue? You inspect for the color. If it is white, then you can suspect leukoplakia or candidiasis. If it is black, you can suspect about black hairy tongue. If it is coated tongue, or covered with a whitish or yellowish layer consisting of desquamated epithelium, debris, bacteria, fungi, you need to check about it. Now, talking about gingiva, you check about the color of the gingiva. You need to check about the contour of the gingiva, depends on the shape of the teeth and they align with the arch. You need to check about the shape of the gingiva. It's governed by the contour of the tracts proximal to the surface and the location shape of gingival embrasures. And you check about the size of the gingiva. Talking about the consistency of gingiva is firm and resilient with exception of pre-gingival margin. Surface texture, generally orange peel in appearance. Stippling is generally absent in infancy and old age. Attached gingiva and central portion of the interindented gingiva is stippled, whereas the margin gingiva is not. Remember that. And stippling is produced by alternate with rounded protuberances and depression in the gingival surfaces. Check about the position of the gingiva refers to the level at which gingival margin is attached to the tooth. You need to check about the recession in the gingiva. If there is generalized recession, the disease progresses from gingivitis to periodontitis. There's a classification by according to P.D. Miller's about the recession. It's class 1, gingival recession not extending to mucogingival junction. Class 2, gingival recession extending up to the beyond mucogingival junction. Class 3, gingival recession extending up to or beyond mucogingival junction, bone and soft tissue lost indefinitely. And class C, gingival recession extending up to or beyond mucogingival junction, severe malposition of teeth. Now, what are the causes of gingival recession? It can be faulty tooth brushing technique, tooth malposition, high final attachment, trauma from occlusion, or orthodontic movement of the teeth. Talking about the salivary glands, you need to check for the parotid glands. Position is located below, behind, and slightly in front of the ear. Swelling of parotid gland obliterates the normal hollow just below the lobule of the ear. The duct of the salivary gland opens the oral cavity on the buccal surface opposite the crown of the maxillary second molar. If it is suppurative proctitis, gentle pressure of the gland will cause purulent saliva to come out of the tongue. Terminal part of the duct is palpated bidigitally between the index finger inside the mouth and the thumb over the cheek. Blood will come out of the duct in case of malignancy. Talking about the submandibular gland, if there is any history of swelling with pain at the time of meals suggests obstruction in the submandibular duct, it is tense and painful. Now, duct of submandibular gland is the Watson's duct. It's inspected by means of torch on the floor of the mouth, which is situated on either side of the lingual sphincter. Check if the duct orifice has swollen or inflamed. If the gland is infected, slight pressure on the gland will exude pus through the orifice. Stone is suspected in one duct, saliva will be soon coming out with normal flow from other orifice while affected duct orifice remains dry. The test, which can be done, we test by putting dry sweets on each orifice and some lemon juice on dorsum of the tongue. 2 minutes after sweets on one side are taken out, sweets on the orifice of the duct where the stone is impacted will remain dry. If the patient gives history of pain during or after the meals, ask the patient to suck little lemon or lime juice. If swelling appears, it indicates stone in submandibular duct. Talking about the bimanual palpation, patient is asked to open the mouth. One finger of one hand is placed on the floor of the mouth, medial to the alveolus and lateral to the tongue, pressed on the floor of the mouth as far as possible. The finger of the other hand on the exterior is placed just medial to the inferior margin of the mandible. These fingers are pushed upwards as this will help to palpate both the superficial and the deep lobes of submandibular salivary gland. This also differentiates the enlarged salivary gland from enlarged submandibular still lymph nodes. Now, submandibular salivary gland enlargement is a single swelling, whereas nodular swelling suggests lymph node enlargement. Now, whenever the patient comes in the clinic, generally many patients have a complaint of swelling. So you need to know how to examine a swelling. First of all, see for inspection. Go for inspection, see for the situation of the swelling. Few swellings are peculiar in their position, like dermoid swelling, midline of the body. Median parietal cyst is midline of the hard palate. Lobulomaxillary cyst between the maxillary incisor and the maxillary canine. Median mandibular cyst is midline of the mandible. Check the color of the swelling. If it is black, it can be benign nevus. If it's red purple, it can be hemangioma. If it is bluish color, it can be a granular. Check about the shape of the swelling. Now, if it is ovoid, pear-shaped, kidney-shaped, spherical, or irregular. Check about the size of the swelling. Always the vertical and horizontal dimension of the size of the swelling should be noted. Surface of the swelling should be seen if it is smooth, ulcerated, papillomatous. Edges may be clearly defined or indistinct, sessile or pedunculated. How many swellings are there? You need to see that also. What is the movement of the swelling with the respiration? Note that swelling that arises in the upper abdominal viscera move with respiration. Impulse on coughing. Swellings which are in continuity with the abdominal cavity, pleural cavity, spinal cavity, or cranial cavity give rise to impulse on coughing. Movement with deglutition. A few swellings which are fixed to larynx or trachea move during deglutition. Movement with protrusion of tongue. Thyroglossus move with the protrusion of tongue. For the skin of the swelling, if it is red and edematous, it can be inflammatory swelling. If skin becomes tense, glossy, and venous prominence, it can be a sarcoma with rapid growth. Black puncture with the cutaneous swelling, it can be sebaceous cyst. Presence of a scar indicates previous operation injury. Pigmentation of the skin seen in moles, nevi, or other repeated exposures of the X-rays. Now you need to after inspection, you need to palpate the swelling. See the temperature of the swelling. Best felt with the dorsal aspect of the tongue. First, know systemic temperature. Then only you can know the temperature of the swelling. Check about the tenderness of the swelling. Inflammatory swellings are generally tender. Neoplastic are not. Size of the swelling. Deeper dimensions of the swelling remain unknown during inspection. So on palpation, you need to see the size of the swelling. Shape. Vertical and horizontal dimensions are best clarified by palpation. You need to see the extent of the swelling, whether it is well defined or ill defined. Now you have to see the surface of the swelling on palpation. You need to see the edges or borders on palpation. Smooth margins are benign swellings and irregular margins generally suggest malignant swellings. You need to go for the consistency or degree of firmness of the lesion is contrast to that of the surrounding tissue. A soft consistency generally indicates a cyst, Warthin tumor, vascular tumor, fatty tumor, inflammatory hyperplasia, tension phenomena, cystic hygroma. A cheesy consistency can be a cyst, rubbery consistency can be cyst under tension, myeloblastoma, lymphoma. Firm consistency can be an infection, benign tumor, malignancy, osteosarcoma. If it is bony hard, it can be osteoma, osteogenic sarcoma. If it is soft, it can be easily compressible tissues such as lipoma. If it is cheesy, it indicates finer tissues that is granular sensation but no rebound. Rubbery tissue that is firm but not be compressed slightly and rebound to normal contour as soon as pressure is withdrawn. Firm fiber tissue that cannot be easily compressed. Check about the fluctuation. Swelling fluctuates when it contains liquid or gas. How do you test fluctuation? It's carried out by one finger of each hand. Sudden pressure is applied on one pole of swelling. This will increase pressure within the cavity of the swelling and will be transmitted equally at right angle to every part of this wall. Another finger is placed on other side swelling, or the finger will raise passively due to increased pressure within the swelling. This means swelling is fluctuating. Test is performed in two planes at right angle to each other. Two fingers are kept as far as possible to size swelling will allow. In case of small swelling where it cannot accommodate two fingers, fluctuation is achieved by pressing the swelling at the center. The swelling containing fluid will be softer at the center than its periphery, while solid swelling will be firmer at the center than its periphery. Now check about the translucency. Swelling will transmit light if it is translucent. The impulse on cuffing. Swelling is grasped and patient is asked to cuff. The impulse is felt by grasping hand. You should know the difference between reducibility and compressibility. Reducibility is the swelling can be reduced and ultimately disappear as soon as pressed upon. Compressibility is swelling can be compressed but cannot be disappear completely like arterial, capillary, venous hemangioma. Now, pulsatility, a swelling may be pulsatile, arise from the wall of an artery or lies close to an artery, or if the swelling is a vascular one. Pulsatile one is two fingers are raised with each of the artery. Expansile one are two fingers are raised and separated from each other. Transmitted one are two fingers are raised but not separated, called transmitted pulsation. Now you need to check about the fixity of the overlying skin. For this skin is made to move over the swelling. If it is fixed to the skin will not move. Try to pinch up the skin overlying the swelling in different parts. If it is fixed, it cannot be pinched off. If it's not fixed, it can be pinched off. Swelling is freely movable if it is benign and encapsulated mass. Last is aspiration. You need to aspirate the swelling. You need to see what color fluid is coming. The straw color fluid contains cholesterol crystals, like odontogenic keratosis. This thick yellow, fish white, and granular fluid, epidermoid keratosis. Sebaceous cyst contains a sebum which is thick, homogeneous, and yellowish cheesy substance. Dark amber color fluid, thyroglossal duct cyst. Lymph fluid, colorless with high lipid content. Blue blood is seen, then can be a hematoma, hemangioma. A bright blood is seen, it can be aneurysm or AV fistula. Now, in actinomycosis, you will yield pus with yellow granules. In sticky clear viscous fluid is there can be a retention phenomenon. After the soft tissue, we talk about the hard tissue. The hard tissue consists of teeth present, size, color, structural changes, eruption, retained deciduous tooth, and any trauma to the tooth. Check about any tooth which is missing in both the arches. Check about the caries. Now, primary is visual inspection, probing, percussion, and transmission. You can check about the caries within the tooth. Basic tools required are a good light source, a mirror, a sharp explorer, and an air syringe are the most basic tools required for checking of the caries in the tooth. Another method to check caries is the radiographic methods. So by doing radiography, you can go for intraoral periapical radiograph. Okay, the disadvantage is basically radiographically visible mineral loss should be more than 20 to 30%. And then you need to check about the wasting diseases of the teeth. That is one of these is adhesion. Now, physiological wearing away of the tooth is the result of tooth-to-tooth contact as seen in mastication. It occurs in the occlusal incisors proximal surface of the teeth, seen in bruxism, traumatic occlusion, and other also associated with the aging process. Not another wasting disease is the abrasion. The friction between tooth and exogenous agent. The etiology is use of abrasive dentifrice. Other wasting disease is erosion, defined as irreversible loss of dental hard tissue by a chemical process that does not involve bacteria, generally present in cervical areas of the teeth. Etiology can be intrinsic or extrinsic. Intrinsic can be gastroesophageal reflex and vomiting, and extrinsic can be acidic beverages and citrus fruits. These are my references. Thank you.